Greetings from the Philippines. I was asked to answer this question: is there a need for the World Headache Society? I would like to go back to an old document entitled Atlas of Headache Disorders and Resources in the World in 2011. And what was the main conclusion? The main conclusion was there is worldwide neglect for patients with primary headache, in particular migraine and tension type headaches. The survey revealed the lack of existing services, availability of resources, and delivery of care for this major cause of public health. These are the key recommendations, and as an epidemiologist, we always say, what you do not measure, you cannot change. My proposal to conduct a survey on delivery of care for migraine in the Asian Oceanian region was approved by the Asian Association of Neurology, and so far this is work in progress. We have 18 of the 20 countries having responded, and we were able to invite also 4 non-AOAN countries to participate in this survey. Overall, when it comes to organizational structures, all countries have an official neurological association, but only 11 out of the 22 countries, or 50%, have a headache council. And when it comes to specialized headache units, only 7 or 32% have these units. When it comes to lay organizations dedicated to headache, 9 out of the 22 countries have such organizations. We divided the responding countries into 2 groups based on the World Bank country classification by income level of 2020. So the lower income group were the countries that belong to the low and middle income category, while the upper income group, consisted of those belonging to the upper middle and the high income group. Regarding the availability of prevalence studies, this slide would show that 58% of the upper income group have prevalence studies compared to 40% of the lower income group. The need for availability of clinical practice guidelines was stressed in the 2011 Atlas. And you can see here that only those belonging to the upper group or upper income group have clinical practice guidelines. That's 67% compared to 0% in the lower income group. Only 5 countries offered subspecialty training for headache, and only 2 would offer this to foreign graduates. Now, how many hours of lectures are allotted for primary headaches in the medical schools? The survey showed that 75% of the countries would have only 4 hours or less than 4 hours for this. And this is important because headache patients would seek first the help of primary physicians, and they should be well educated on this condition. When it comes to government support, this slide also would show that 92% of the high-income group would have reimbursement for their abortive treatment for migraine compared to only 30% in the lower income group. When it comes to availability of migraine-specific drugs, all countries except for 1 have at least 1 triptan, mainly sumatriptan, available in all countries, and some countries have 3 or more triptans, with some having the nasal form or the intravenous form, particularly of sumatriptan. Ergotamine is an old drug. It's available in 45% of the countries. And when it comes to the new drug, the CGRP antagonist, these are available in 8 of the 22 countries. The above data is just part of the survey and it's still work in progress, but it shows us the Marked variations in the delivery of care for migraine patients exists depending on the available resources and economic status of the country. But there is always room for improving the existing delivery of care influenced by knowing and sharing of best practices of neighboring countries. We see a need to improve education not just of our doctors but also for the patients. And this is through the availability of more advocacy programs, more lay organizations dedicated to headache, more headache specialists in the region, and more subspecialty training for headache. The creation of local guidelines or the adaptation of foreign guidelines will help improve and standardize essential care for our migraine and headache patients. Researches on prevalence, impact, and burden due to migraine are lacking. There is need to increase the allocated time for lectures on primary headaches in medical schools. So, with so many unmet needs for headache patients in the region and worldwide, a need for collaborative, multidisciplinary, and even multi-regional approach is needed. And if we go back to the primary question, is there a need for the World Headache Society? My answer is yes. And I would like to acknowledge the collaborators. Again, this is work in progress. Thank you very much for their participation and for sharing with you our data.